a pleasure to be here and getting an audience almost full, although it's a early morning session. And nystagmus is a subject which generally acquires nystagmus in the people who are sitting there. I hope you are not suffering from nystagmus. Most of this has been covered, so I'll switch on to the surgical management. Basically, remember that you have to see the abnormal head posture, but in that you need to measure how much is the head posture, and you can use a simple device like a scale and protractor to align with the visual axis that the child is having, and you can measure the angle on your protractor. You have to always remember that there could be cases of periodic alternate nystagmus which you can miss. So unless you observe them continuously for about 3 to 5 minutes, you will easily miss periodic alternate nystagmus. These are cases which will have to be managed differently by using an approach of supramaximal recession surgeries on the 4 horizontal recti, 2 in each arm. When you are documenting, you can document in any way, but mostly what we prefer is the number of lines indicating the amplitude of nystagmus and the number of arrowheads indicating the frequency of nystagmus in the direction can be indicated as well as torsion. But also remember that you need to document vision in the 9 gazes, and that will help you how much the vision in different gazes. Electrodystagmography and all this has been covered, and video nystagmography is another interesting tool. The 4 types of nystagmus that we mostly deal with in children, particularly in infancy, is the infantile nystagmus syndrome, which is the most common. About 80 to 90% cases will be in this category. Then we have the fusional maldevelopment nystagmus or the manifested nystagmus. But the cases which have squint, there would be about 90% of cases which have squint. This would be the nystagmus that we deal with. Then there is a smaller segment of spasmus nigrans syndrome and the nystagmus blockade syndrome. In the non-surgical management, which is already been covered, we have some personal experience of auditory biofeedback which we have published, and even the acupuncture in nystagmus. But the only thing I would like to comment here is that although acupuncture is working, when you are giving the acupuncture needles and the twirling of the needles is being done, it does dampen the nystagmus, but there is hardly any effect which remains afterwards. So coming to the basic thing which works is surgery. Surgical management principles in nystagmus is one, to shift the eccentric nerve to the primary position, and this is in the form of Anderson or Anderson testing procedure. The second strategy which can be used is using convergence by surgically deepening the medial recti and using the Hendricks-Pillman's approach. Third is damp the amplitude of nystagmus by retroequatorial or supramaximal recession of the 4 horizontal recti. Remember the 4 horizontal recti and not the 4 recti in one eye. That's the DT's procedure. Then the proposed altering of the proprioceptive reflexes by Hertel and Derosol's 4 muscle horizontal rectus to not be used. Basic planning for Anderson-Castellman procedure is, as we just saw earlier, that we will notice the head posture which is abnormal, and consequently there will be a null position which is eccentric. And if, like in this picture, you have a null position which is in the extroversion, then we need to shift the eyeball to the left side, and this can be done by a right LR recession and a left MR recession, and that would make it an Anderson's procedure. If you add the resection component, that is the right MR resection and the left reflectus resection, then it becomes a Kestenbaum procedure. If you do only the resection component, then it is the Goto's procedure which is being described. And this is preferably done after 5 years of age, because we see that the nystagmus and head posture may keep on varying in about 4 or 5 years of age. So this surgery is better deferred in this case. The important thing is, in the nystagmus surgery, we have to do larger amounts if you are doing Anderson's. Like for example, an LR recession of 12 mm from the insertion. So it's about 18 or 19 millimeters from the limbus. So how do you do? This is a little tricky procedure. As far as surgery is concerned, that you would have to. Now this is showing the 6 ovicular sutures pass as usually we do in the stethoscope surgery after upon its incision, and now the muscle is being disinserted. Now marking is important here, that you are going to mark it in 2 sets, like 6 and 6, because one 12 mm measurement would not be as correct. It will be an arc versus a chord measurement. So you can do in 2 halves, 6 and 6 millimeter, and then mark 12 mm from the insertion. And then you can pass the needles partial thickness bites as usual. So nothing more than this is the tricky part of the surgery. Main thing is the planning. After the surgery and augmented medicine procedure, you will get a shifting of the null to the primary position, and that corrects the head posture. The various procedures which have been described in the literature, Anderson had described the yoke muscle resections, as we said. Kestenbaum described the 4 muscle resection, doing all the 4 horizontal lecture 5 mm, and then Parks came up with the classic approach of 5, 6, 7, 8. But this was found to be insufficient, so augmented Parks, 40% or 60% augmentation was there. We earlier have been doing an MR recess procedure of 6, 6, 9, 9, and recently we have found that up to 30 degrees of null eccentric can be easily corrected by augmented Anderson's procedure, which is medial rectus 9 mm and a lateral rectus 12 mm, as we have shown. And this is the pre-op and the post-op picture of a girl. But remember, what is going to happen sometime if you miss a periodic alternating nystagmus. If you have a case of PAN and you have done augmented Anderson's procedure, you will see the reversal of the head posture to the opposite side. So what we need to do is, this was the first 2 pictures show you the first day and the second day after the surgery of RMR and left lateral rectus. What you need to do on the 3rd day is correct the right lateral rectus and the left medial rectus recession. Again an augmented Anderson but reverse. Now this becomes a supramaximal recession of all the 4 horizontal recti, and that is a procedure which we would like to advocate for a primary case of a periodic alternating nystagmus. So this is the electronystagmography before and after the surgery. A case in this, and we have found that the face turn dramatically improved from about 35 degrees down to about 5 or 10 degrees, which is acceptable. There would be some limitation of movement if you are doing augmented Anderson's procedure, but this self-corrects by about 1 month's time. If you have an eccentric null along with a strabismus, then you need to do a little more of cortical thinking, and what you need to do here is see which is the dominant eye. The nystagmus surgery has to be done on the dominant eye, and the strabismus surgery has to be done on the non-dominant eye. So first we need to identify which of the eye is dominant. If there is an esodiviation, and the esodivating eye is the dominant eye, then it's much simpler. It's like you can strike 2 birds with 1 stone. You can do a recession of the right medial rectus in the first picture as you see, and that would correct both the nystagmus and the esotropia. But if you have, let's say, an exodeviation and still the right eye is the dominant eye, and if you need to do an MR recession of the dominant eye, it would increase the exodeviation. So you would have to plan the R and R of the other eye to correct not only the pre-existing exotropia but also the exodeviation which you would have created by your nystagmus surgery. So this is the part of the planning that you need to do. In the vertical posture, again the same posture works, and you would shift the eyeball by doing the requisite vertical muscles by chin up and chin down positions. For torsional head tilts that we have, an oblique torsional Kestenbaum procedure is described. D. Decker had described the horizontal recti shifted vertically. Von Ulen described the vertical recti shifted horizontally, and then there is an approach of oblique muscles in which the torsional anterior fibers are selectively weakened or strengthened by recession or advancement and resection. And this is usually the approach that we prefer, although it's more difficult, but because it does not compromise the circulation of the vessels by the horizontal or the vertical recti. So this is like a case in which you have a right-sided head tilt, and you can also see in the electronystagmography that the null position is shown on the left column, and the right tilt, the null is there. So in this case, if you do a surgery to correct this, it will work. So what you need to do if you approach by D. Decker's or a Von Ulen's approach, it's shown in the right. But if you do the obliques, you operate on the anterior fibers, the right superior oblique and the left inferior oblique recessions, and the right inferior oblique and the left superior oblique advancement plus resection of about 8 mm each, and that will usually correct the head posture to this form. The 4 muscle recessions, as we do for the peak to the periodic alternating nystagmus, or cases which do not have a null position, we have seen it does damp the nystagmus to some extent, but unfortunately we have seen that the effect passes off by about 3 or 6 months' time, so there is not much of lasting value of this surgery. The convergence dampening mechanism by artificially weakening the medial rectus by means of prisms. You can try it, or you do a bi-medial recession of 5 to 12 mm as has been reported by Annex Spellman. But unfortunately, if you see the results of the 75 cases which have been reported, there was a success of 26% only, and 9 out of the 75 cases had unfusible exotropia. So you have to be very much aware of this possibility. Medical treatment has been covered. So to conclude, basically cases which have a definite eccentric null up to 30 degrees, they respond very well to an augmented endoscopy procedure. What we mean is the medial rectus is done about 9 mm and the lateral rectus 12 mm recession. For more than 40 degrees, we add the resection component of the opposite muscles. If there is a periodic alternating null, we do the bilateral augmented endoscopy, or it's a supramaximal recession of all the 4 horizontal recti. If you have a case of fusional maldevelopment nystagmus with associated squint, you just size the squint, and usually the manifest latent nystagmus becomes purely a latent nystagmus. If you have no definite null, different things have been tried like auditory biofeedback, acupuncture, 4 muscle supramaximal recessions, or even the Hurtle-Deloso procedure. These may be done. We have tried all these in cases, but we see that the effect is not lasting more than 3 or 6 months. So this is the status that we have at the moment. Thank you.